renowned scientists join us from the UK. We're especially grateful because it's 5 o'clock on Saturday night in the UK. So thank you guys so much for joining us and sharing your Saturday night with us. I really appreciate that. So I'll go ahead and do introductions. Dr. Angelica Zarkali is a neurologist working on neurodegenerative diseases in the Dementia Research Center at the University College of London. She is interested in the etiology, the diagnosis, and treatment of Parkinson's disease, as well as dementia with Lewy body. Her research aims to shed light on the neural correlates of visual hallucinations and cognitive fluctuations in Parkinson's and Lewy body dementia. She is currently studying how changes in brain circuits lead to hallucinations and cognitive fluctuations using ultra-high MRIs. So hopefully we'll hear a little bit about her really interesting research that she's doing. So thank you for joining us.
Thank you for having me. I'll try and share my screen to begin with. Let me know if you can see everything okay.
Yeah. So first I wanted to just remind everybody that the format for today, we're going to, Dr. Zarkali is going to share her slides on some of the basics about hallucinations and their relationship with Parkinson's. And then Dr. Reeves, who I'll introduce later, will go into a little bit more about the treatments, some of the treatment options and some of the medications and a clinical trial that she's going over. Is that your screen that says Zoom quit unexpectedly?
It is, but I'm still here. So I'm not sure.
Okay, maybe just close it out. That's odd. And again, just a reminder, if anybody has
I'm still here.
Okay, you can go ahead and share your screen again.
It's probably the sharing that did it. Let's try again. Let's try this. How's that? Can you see?
Yes. And just to confirm, we are recording this session. We had a question in the chat about that. And yes, it is 5 o'clock in London. 9 o'clock here and 5 o'clock in London.
That's another Zoom quit unexpectedly. Great.
Well, we can see you and hear you, so maybe just keep going.
Okay, cool. All right. I'll try that. So thank you for having me. I'm Angelica, and as not Cathy Monique even. I'll just talk to you a bit about how and why hallucinations happen in Parkinson's. So things that I will try to cover is what are visual hallucinations, what do people with Parkinson's who experience hallucinations actually see, how that interplays with healthy human vision perception, and what changes in visual perception lead to hallucinations in Parkinson's. So most of all of us, actually, when we think about Parkinson's disease, we think about movement and problems with movement. But actually, as I'm sure you all know, non-motor symptoms are quite common, and particularly symptoms with vision, including kind of seeing more blurred or having double vision, or visual hallucinations are actually quite common, with up to 40% of people who have Parkinson's disease experiencing them. And they can be very, very detailed and distressing. And it's really interesting that it's a symptom that is not very common in other neurological diseases. And it seems to be very common in Parkinson's and the related dementia with Lewy bodies. This is just a short clip. I hope it will play of one of our participants. We did an animated film with a very brilliant animator, Simon, about hallucinations, and this is kind of some of their experience of them. Hopefully you can hear it.
He told me that there was a salty tar sitting on the dining room table fishing. Complete with a great big beard. The oil skin was a really dirty yellow, really, really detailed. That you actually almost wanted to go and look and think, well, what the heck is he looking at?
So hopefully you can see by that kind of experience that I have a poll. Should I pose that, Monique, and people can answer, or?
Yeah, I meant to put this in a bit earlier, but why don't we go ahead and just do this routine poll real quick to see kind of what the audience is here today. I would imagine there might be a lot of caregivers as well as people with Parkinson's, because I think that hallucinations is probably one of those symptoms that affects the whole family unit, and not just the individual.
If
Yes,
anyone
so
can answer that. Paul?
I'll just give it a few more seconds. Sorry to interrupt, Dr. Zarkali.
No, that's absolutely fine. It's actually good to know.
Okay, I'm going to go ahead and end the poll and publish the results.
Yeah.
So yeah, it looks like we have about 65% of people with Parkinson's and about 33% of caregivers. So that's a little higher, 16% of concerned family members.
Fair enough. So hopefully this will be kind of applicable and relevant to all of you. Do you want to do the
Yeah, let me go ahead and do the
second
next one so we can kind of also get a sense of how many people in the audience are experiencing hallucinations. So if you guys could go ahead and just take a minute to answer this poll with yes, you've had them a few, or you have them regularly, you know, every day or every other day, or know that you haven't had any at all. I've got about almost everybody chiming in, so I appreciate everybody doing that. Okay, looks like we've had about half the audience has never had an hallucination. About a third have had a few, and about 20% have regular hallucinations. Very interesting.
Interesting. So that kind of reflects our kind of 40% figure as well, although these are kind of varies. In cohort studies, it varies from 30 to 70%. I guess it also depends how long people have had Parkinson's for. So yes, I was saying it's a really interesting symptom that seems to be really almost unique in people who have Parkinson's disease and dementia with Lewy bodies. And the other interesting point is that visual hallucination in Parkinson's are very varied. So there can be what we call minor hallucinations, such as illusions or misperceptions. For example, here, hopefully you can all see kind of there's some towels and some dogs, and towels may look a bit like dogs and dogs a little bit like towels, but hopefully you can discern quite easily between the two. But sometimes some people with Parkinson's maybe misperceive or make mistakes initially. So they might see a towel or pile of clothes on the floor and mistake it for a dog or a cat, for an instance, and then you look again and oh, it's a towel. And another very specific and common type of illusion is seeing faces when there are none, and this is called pareidolia. And all of us experience this to a degree because our brain is essentially wired in seeing patterns. So, for example, you can see that this kind of rock formation looks like an elephant, but in people who have Parkinson's disease, we know that this is more exaggerated. So, for example, they may see faces in objects that you wouldn't normally look like faces to other people. This photograph of these flowers were repeatedly perceived as staring faces by a 74-year-old lady who had Parkinson's disease. And another common minor hallucinations that you may have experienced is what we call passage hallucinations, where there's a feeling or a shadow that is just moving in the corner of your eye. And we also can have very, very detailed hallucinations that are the ones that with the fishermen in the dining room. So it's a very vivid visual scene that looks almost lifelike. And this is kind of interesting painting from Charles Doyle, which is Arthur Conan Doyle's father, who we don't know whether he had Parkinson's or not. He spent his final days in an asylum in Scotland. But it's a really good representation of the complex hallucinations that people with Parkinson's experience, which are usually people in the house at night, plants or furniture turning into people or children, or animals or little cats running around the floor. And trying to understand how and why visual hallucinations happen, it's important to know and understand better how we perceive the visual world around us, so how visual perception works. And one really important point is that vision is an active process. So, and it differs for each one of us. So you may remember a few years ago, there was this dress image in the internet that different people perceived as blue or black and different people perceived as white and gold, but it's the same dress. How can different people perceive it differently? And that is because each of us interprets the world around us. Even though we see the same object, we perceive it differently. And that is because vision is influenced by previous experience. Another really good example of how previous experience influences the way we perceive visual information is this brick wall. And if I ask you now to take a moment to look at this and ask yourself whether you can see any objects in this photograph. So some of you may be able to see an object. Likely most of you will just see a brick wall. But if I now highlight the object to you, the cigar in the middle, and then I show you the exact same picture, the cigar is now really easy to perceive. It kind of pops out. And if you see it, you can't really unsee it. So having seen it once influences the way that you perceive the exact same photo. And vision is also influenced by context. So if you see this shadow and nothing else, what will you think it is? Well, if you're standing outside your house or in a park, you might think, oh, it might be a puppy. If you're hiking in a forest or kind of skiing in Colorado like Todd is, maybe you will think it's a wolf howling. So how we perceive things and how we make decisions about what we see is influenced by both our experiences and also the situation that we are in. And that is important because it leads to mistakes. So our vision is not foolproof. And actually, both cases were wrong in this case. And the shadow was actually from the cats. So thinking about how we perceive things, there are two major influences on vision. So we can think of the bottom-up influence, which consists from the visual information or the sensory evidence that our eyes gather and send to the brain. So for example, you see kind of brush strokes here, which could be many different things. But we also have a top-down influence. So for example, the memory, goals, expectation, the context we're in, the situation, which we call all that prior knowledge. And in this case, you have a prior knowledge of how a lily pond may look like. And both these things combine together in the brain to produce a final perception of this kind of painting of a lily pond by Monet. So it's not an actual lily pond, it's the same brushstrokes that you saw before, but because you have this prior knowledge, you perceive it fully with both the bottom-up and top-down influences. So how does this visual perception process changes in Parkinson's disease? Well, we know that vision can become affected in Parkinson's. So people with Parkinson's sometimes have difficulty copying these intersecting pentagons. So if we ask people who have Parkinson's and don't have Parkinson's to copy this image, a larger proportion of people with Parkinson's will not copy it perfectly than people who don't have Parkinson's. And we also know that sometimes there's problems with the perception of colors. So this is a test where we give people discs of different shades of colors and we ask them to put them in order. So these are not ordered that you see there, but we ask them to put them in order from like a red to blue. And we find that people with Parkinson's can make mistakes in the different kind of colors compared to people who don't have Parkinson's. And also, there is even at the back of the eyes, the retina, where the first point of the visual system where information from the world kind of hits us and gets transformed into electrical signals, there is thinning of certain layers of the retina in the back of the eyes in Parkinson's disease. And even if we think about the most basic visual tests, which I'm sure you all have experienced going to the opticians and just reading this screen, we call this visual acuity. People with Parkinson's, and even before they get diagnosed with Parkinson's, can sometimes do worse in those tests than people who are later diagnosed with Parkinson's. And this is not because of glasses, it's just because of the way that the brain perceives visual information. So if we go back to our model of visual perception, so all these eye test problems that I showed you are related to these bottom-up influences. So the sensory evidence that you get, the information from the eyes is not as pristine as it should be. But that happens in a lot of other conditions and doesn't really explain the very, very vivid, complex visual scenes that people experience. So what we wanted to find out initially, kind of when I started my PhD a few years ago, was whether there is also change in top-down influence, so prior knowledge. And what we did was use these two-tone images of black and white patches. So again, if I ask you to take a few moments here and kind of ask yourself, can you see a person in this image? So some of you may have said yes, some of you may have said no. But if I now showed you the image that we used to produce the previous one, the template colored image, and then I show you the same image again, as with a cigar in the wall, hopefully you can now all see the outline of the baby taking a bath. And that's because you were given prior knowledge. And once you see it, you can't unsee it. So we use these two-tone stimuli, and we invited 57 people to come along and take part in the study, and we collected a lot of data on their movements, on whether they had hallucinations or not, how severe the hallucinations were, and performed a lot of memory and visual tests to make sure that people with and without hallucinations did not really differ in any other factors. And then we showed people these two-tone images, and some of them, as the one on the top, had people in them, and some of them, as the one in the bottom, did not have people in them. So this has actually an animal in it. And then we showed people the templates from which the two-tone images were produced. And then we showed them the exact two-tone images again. So we had a before block, a template block where people were given prior knowledge, and an after block where they were seeing exactly the same sensory information, but they had received the prior knowledge. And we measured how good people were in identifying the person, the presence or absence of a person in the image in the before and after block. So comparing the performance in before and after, we were able to actually quantify how people used their prior knowledge that they received in the middle. And what we found was that everyone's performance improved after receiving prior knowledge, which is what we expected. So if you know the image, you perform better. But interestingly, people who had hallucinations, although they started from a lower performance to begin with, they improved almost twice as much as non-hallucinators did. So with orange here, you see the people who experience hallucinations, and with green, the people who don't experience hallucination never. They both have Parkinson's disease, and you can see the people who experience hallucinations improved so much more after receiving prior knowledge. So they rely in their prior knowledge more. And we also looked at how the relationship between the severity and frequency of their hallucinations with prior knowledge, with this improvement. And the more severe hallucinations, more frequent, more vivid people had, the more they improved after they received this prior knowledge. So they actually used their prior knowledge more. So this implies that people who have Parkinson's disease and visual hallucinations rely more on their prior knowledge than people without hallucinations, because giving them prior knowledge had a significantly bigger effect on hallucinators compared to non-hallucinators. And this overweighting of reliance was associated with hallucination severity. So people who have Parkinson's disease and experience hallucinations have that imbalance in these contrasting influences on vision. But why does this happen? What changes within the brain could lead to this? Well, if we think about these perceptual influences, they require different brain regions to communicate and talk to each other. So, and that happens in the healthy brain through brain wiring, so physical connections between regions. And broadly speaking, the brain consists of like the gray matter on the outer shell here, where the bodies of the neurons are, and then there's white matter inside, which is the connection between different regions. And we know that for hundreds of years, as you can see, this beautiful illustration of the 1900s, that white matter consists of distinct tracts. So this is, for example, the cingulum here connects regions on the front of the brain to the back of the brain. But in the 1900s, they could only see these changes in the tracts by slicing the brains of people after they have died and looking them under the microscope. But now we can actually visualize the white matter, using a type of MRI called diffusion weighted imaging. And here's an example, and it shows from our study actually, and you can see all these tracts that connect different brain regions, and they're colored differently depending on the direction of the information flow. And so we use this technique, the diffusion weighted imaging, to assess the white matter integrity in people who had Parkinson's disease, again with and without hallucinations. And we invited 140 people to take part in this study. Again, made sure that people with and without hallucinations did not differ in any other factors regarding the Parkinson's disease or their age or vision. And we performed brain imaging, including diffusion weighted imaging, to examine the white matter at baseline and again at 18 months. What we found
Angelica,
here,
I'm going to interrupt for 1 second.
yeah, go for it.
This is wonderful. Thank you so much. We had a few comments in the chat asking if you wouldn't mind slowing down just a little bit.
Okay, sorry.
No, it's totally fine. I think that because of your accent, it makes it a little harder.
Yeah, fair enough.
No. So maybe just a little slowing down would be great. Thank you.
I will try, and thank you. It's just I'm trying not to cough as well, so I bet I'm probably talking a bit faster than I would normally. My apologies.
No problem.
Yes, so I was just saying, yeah, so 140 people took part, and yeah, and we did a lot of assessments and imaging at baseline and 18 months apart. And oops, this is just to show you some of the changes that we found. So if you look at the top, you can't see my cursor, but if you look at the top images here, if you imagine kind of that we have the brain, and I've labeled the up, front, back and down, and we essentially have a slice of the brain this way, then that way, and then that way, just to give you a 3D essentially view of the changes that we found. In people who had hallucinations compared to those who didn't have hallucinations ever, we found that the white matter, those connections between brain regions, were thinner in the back of the brain here. So this is called the corpus callosum, and it connects the left and the right of the brain, the back regions of the brain where the visual centers of the brain are. So this was a region that was thinner in people with hallucinations. And what we found was that when we repeated the same imaging 18 months later, oops, hopefully you can see that now, there's a lot more thinning of different tracts. Again, they're mainly in the back of the brain, whilst the connections that connect frontal regions of the brain to the back of the brain are relatively less affected. And this is an interesting finding because these top-down influences to perception that I mentioned before come really from the frontal areas of the brain, so like the prefrontal cortex, which is right here. So it kind of explains the changes that we saw in the behavioral experiment before. So at least partly, just because the back of the brain connections are affected, but the frontal ones are not. So the white matter fibers are thinner in people who experience hallucinations, and we see, interestingly, these changes continue over time. And this is also interesting because if we could use the hallucinations as a biomarker, hallucinations can, well, not often, but sometimes you can start having these hallucinations, and then you develop problems with thinking memory more globally, and that kind of changes in the connections between brain regions may explain why that happens. So if we develop better treatments for the thinking and memory problems, we can actually use them earlier at the first stages before this whole thinning of the white matter tracts happens. And in contrast, we also looked at the same cohort for changes in the gray matter, the outer shell of the brain that I talked about before, and that was actually quite preserved. So that is also interesting because it shows, and other groups have validated this, that actually looking at the white matter, the connections, the brain wiring, may be a more sensitive marker than looking at the gray matter, which is what we traditionally do using MRI in Parkinson's disease. And
So Angelica, yeah. Are you just to interrupt, are you saying that when you see the changes in the white matter and the hallucinations are sort of a precursor for possible cognitive development? And if somebody is having hallucinations, you could maybe sort of try to treat them to sort of delay cognitive impairments?
Yeah, so that we know from a lot of cohort studies, but also in our group we have seen that hallucinations are linked to a higher risk of developing problems with thinking memory and being diagnosed with dementia later on. And from our study, we found that people who had hallucinations at baseline, 18 months later, they had shown reduction in this, they had thinning of these white matter connections. So it definitely seems that there is something that heralds kind of something else happening in the background of the brain. So yes, the hope is that we can actually use hallucinations as a treatment point for these whole thinking memory problems that happen in Parkinson's, and treat that earlier, before you lose these connections.
Interesting. Thank you.
Yeah. So hopefully I'm trying to kind of show you how understanding more about kind of the visual perception in the brain can help us understand better how that goes wrong in Parkinson's disease. So yes, there are changes in the visual system, even at the eyes, at the level of the retina, so the back of the eyes. There's also differences in the influences during vision. So there is an imbalance of an overweighting and over-reliance on prior knowledge, which we think may actually be, could well be an adjustment to the visual change that we see, but maybe it's the way that some people's brains are wired to begin with. And we also see changes in brain wiring that lead or are associated with visual hallucinations. And I think this is a really important topic. So over 2 million people live with Parkinson's disease worldwide. Hallucinations can be distressing and frightening, although not always, and can lead to different thinking and memory problems. And better understanding of the changes of the brain structure and wiring at different levels may help us understand how these changes evolve over time. And we can identify these changes earlier using the correct imaging tests, and potentially use these imaging techniques to test possible treatments by assessing whether they can prevent these changes in brain wiring. And hopefully, by better understanding why hallucinations happen, we can also kind of develop new therapeutic targets. So thank you, everyone. If you have any questions, I'm happy to take them now or later.
Great. That was a wonderful overview. Thank you so much. I kind of have a high level question about hallucinations sort of in general. I mean, obviously people can have hallucinations without Parkinson's. And I know, for example, with schizophrenia, that might be a common thing. And so can you speak to the sort of differences in hallucinations with people with and without Parkinson's? And also
Yes.
maybe touch upon delusions and sort of how delusions are different from hallucinations.
So it's a really interesting question. So yes, so hallucinations do happen in other situations as well. So particularly in psychiatric diseases, as you mentioned, schizophrenia. What is really interesting is that usually these types of hallucinations do not involve, sorry, do not involve the visual system. So they usually tend to be auditory. So people, apologies, hearing things that are not there, rather than seeing things that are not there. Visual hallucinations are also happening in things like epilepsy, or with certain drugs like LSD or things like that, but they're also different. So they're what we call more simple hallucinations, so shapes, colors, and not these very, very vivid lifelike scenes. These are quite rare outside of Parkinson's and dementia with Lewy bodies, and that's why I think for me it's actually quite an interesting topic, because it seems to be intrinsic to this disorder caused by alpha-synuclein and Lewy bodies. It seems that in other diseases where hallucinations, like schizophrenia, where hallucinations are very common, they're very, very different, and in these types of hallucinations are very common in Parkinson's, but very rare elsewhere. So it's an interesting, it's a very specific kind of type of hallucination. Regarding delusions, a delusion is a false belief. So hallucinations are false perceptions. So you see things or hear things or feel things that are not there, but you don't necessarily believe that they are true. So in fact, actually, in most studies, we see that people with Parkinson's can recognize that this is a false image. So they can become accustomed to it because they tend to be stereotypical. They tend to have the same types of images. So they go, oh, so like that person that we heard from in the beginning, he would be, oh, this is my fisherman. So this is my hallucination. And they wouldn't believe that there is actually a person there. But delusions can happen in Parkinson's as well, like strange beliefs, like that people may be trying to hurt you or steal from you and those sorts of things, but they're not that common. And they are less, they can happen in a lot of other disorders as well, I think, particularly in the context of dementia, but they're not so typical of Parkinson's disease, if that makes sense.
Okay, so it sounds like with Parkinson's, they're mostly visual hallucinations. You can have auditory or other, but it's rarer. And they're also they also tend to be more complex, it sounds like.
Yeah, and also the visual hallucinations are also tend to be the first. So sometimes people get with Parkinson's, at least some of the people that I look after in clinic describe auditory hallucinations that are not clear. So you can't make up conversations. You can hear like muffled sounds or things like that, but they're not as clear as the visual scenes are, if that makes sense.
And so what if somebody is beginning to have hallucinations or currently having them? I mean, what would be the course of action? You would first probably go to your neurologist, your movement disorder specialist.
Yeah.
And what might they do? Would they check your vision first to make sure that it's not just a purely, a problem with your eyes? Or what would the assessment sort of look like?
Yes, I think that's an excellent question. I think it might differ a bit in the States compared to what we do in the UK, to be honest. But in our clinical practice, actually, the non-motor symptoms of Parkinson's are often get ignored. So there's a little bit, we're trying to educate our colleagues actually in the movement disorders clinic to recognize and ask for them more. But as you say, like assessments with vision are quite important, particularly because a lot of people have double vision first, or they make visual mistakes. And I think optimizing vision, so correcting any, using glasses and things like that is really important, because you want your sensory information to be as pristine as you can get it. So you start from a good baseline, and then you have to check. The next thing I would do is probably check the medications that people are taking, because I'm sure Suzanne will talk on this, so I'm not going to go into a lot of details about treatments, but one thing is that we would check the medications that people are taking to make sure that there's nothing that can make hallucinations worse or cause them or contribute, and optimize that, and then think about different treatments. And I'm not going to go into details because Suzanne will talk about that.
Excellent. It looks like somebody from the audience, Herb, has a question. So I'm going to unmute you, Herb, if you would like to come in and ask your question live.
Yes. Hi. Can you see me or just hear me?
We can hear you.
Okay. Well, I don't know how much you've learned about what you've learned about the changes in the brain. How much, and you alluded to this a little bit, but are they rewirings? Are they plasticity in action, or are they destruction, results of the losses directly? But I'll tell you that my thinking is that it's actually helpful to have hallucinations in a way, because I'm learning how my brain my brain's going to do things anyway. And it used to be that my brain would fool me and I wouldn't realize I was seeing something that my brain was using to fill in gaps of perception. And so now I feel like I have a better ability to distinguish when I'm not sure what I'm seeing from when I think I'm sure. I don't know if that makes sense. But I wonder if you had any research, what
No,
you
that
say
is an
about that.
excellent question, Herb. And I think it's something that we're really interested in at the moment. It's really difficult to actually answer because there's we all obviously we assess people after the fact. So we know that there are changes in vision in these bottom-up influences. But we don't know what those people's brains look like before they develop Parkinson's disease. So it could be, as you say, that people kind of lost, like they get the brain gets less good sensory information. So it over-relies, it compensates by over-relying on this prior knowledge, and that works very well up until a degree, and then you start getting hallucinations. Or it could be that some people's brain are just wired to rely more on the prior knowledge than other people. And we know that there's actually the same two-tone imaging study that I showed you has been done also in healthy people who have had a first episode of psychosis. So they had experience of hallucinations without them developing psychiatric disease. And it showed the researchers there showed that they also over-relied on their prior knowledge. So it might be that just some of us, our brain is wired to rely more on our prior knowledge. And then when you get Parkinson's and have this bottom-up influence not working as well as it should, that over-reliance triggers the hallucinations. But we don't really know. And it's a very difficult question to answer because we ideally would want to have the same person before they develop Parkinson's and then after they develop Parkinson's and then compare them. So it's very difficult to actually do that study and be certain, but it's a really interesting question.
Thank you. Does that answer your question, Herb?
Sure. I'd be lying if I told you there weren't more questions, but
No.
thank you. Yeah, yeah.
Well, feel free to put them in the chat, and then when we get to the sort of general Q&A at the end, we can circle back to them if you have any burning questions.
It's a lot easier for me to talk than it is to write.
Oh, perfect.
You know, to type.
Yeah, then just go ahead and raise your hand.
Okay.
Yeah, I'm really curious about the prior knowledge idea that you're like looking into, and does that sort of also just sort of include prior experience? So I'm curious if, for example, if somebody who had, post-traumatic stress and was undergoing, had been through a war experience or other, an accident of some sort, if those sort of prior experiences also sort of percolate up and sort of influence the level and degree of hallucinations.
Yeah, that's really interesting. I mean, we haven't specifically, I don't think anyone specifically looked at this in this context, but now that you mentioned it, actually post-traumatic stress is where you often get these very vivid memories, kind of intrusive memories kind of resurface and at the time when you're kind of experiencing stress. So by definition, you get these very vivid memories. We are actually looking into this prior knowledge a little bit more using at the moment trying to understand using ultra high field MRI, so 7 Tesla MRI, which allows us to actually look at the different cortical layers of gray matter. And because they receive different signals, we can then test essentially at different levels of the brain where this imbalance and where the prior knowledge is used more. So this is something I'm really interested in, and it's something that actually has evolved a lot in terms of perception and hallucinations and in other modalities as well. So in schizophrenia with in the auditory domain, and even in terms of memory and Alzheimer's disease. So with PTSD, it's a very interesting point. I'll go and think about that, and maybe it's a research project there, but I'm not sure that anyone has actually looked at that. I suspect there might be a correlation.
Okay, thank you. We'll have one more question and then we'll move on to Dr. Suzanne Reeves to learn a little bit more about the treatment. There are definitely questions coming in about treatment. Hope asks, do hallucinations always correlate with Lewy bodies in addition to the thinning of white matter? Or do Lewy bodies cause the thinning?
Yes, that's an excellent question. We don't 100% know. So the areas where we found thinning are connections between areas where we do see higher deposition of Lewy bodies in the brain in postmortem studies. So in the visual cortex, in a bit of the brain called the thalamus. So these are areas where we do see more Lewy bodies, and the connections between them we've found are thinned. But again, this is a little bit of chicken and eggs. We can only see the Lewy bodies after the person has died in the microscope, and then we only rely on historical data about their hallucinations when they develop them, what they experience. So it's always more difficult to make that connection. I think it is in other disorders that don't have Lewy bodies and alpha-synuclein in the brain, we do see visual hallucinations, but they're very, very, very rare. So there is these types of hallucinations are very common in association with Lewy bodies and very rare elsewhere. So I think there is a relationship there. Whether that is because of where the Lewy bodies tend to form in the brain and how they disseminate in the brain, or whether it's probably more likely than directly the Lewy bodies causing them, if that makes sense. It must be something about where the Lewy bodies form and how they spread and the areas they affect that produce hallucinations, rather than the alpha-synuclein by its own causing them. So the alpha-synuclein spreads in the brain in a specific pattern, and because of the affected areas, you get hallucinations, if that makes sense.
Great, thank you. It does seem like both of your research focuses on hallucinations in Parkinson's and Lewy body disease. So that seems to be that I take it that the hallucinations that are often in Parkinson's are very similar to
exactly the same. Yeah.
Okay, interesting. Okay, so thank you again, and we'll come back to you at the end with some more questions, I'm sure. And so now we're going to turn it to Dr. Suzanne Reeves, who is also joining us from London. She's a professor of old age psychiatry at the University College in London, also where Dr. Zarkali is. In addition, she's a consultant with the Islington Care Home Liaison Service. So I think she spends a lot of time on the ground in the home with elderly people and people with Parkinson's. Her main research interest is improving the safety of existing drugs and identifying novel treatments for people with delusions and hallucinations in Parkinson's, Alzheimer's, and Lewy body disease. She's also the chief investigator of a clinical trial, multi-site trial called Top Hat, which is evaluating a novel treatment for hallucinations in Parkinson's and Lewy body. And we'll learn a little bit about that during her talk. So thank you so much for joining us. You can go ahead and share your slides and get started.
Yeah, so well, thank you very much for the invite. And it's great to see so many people here. Am I loud enough for everyone? Yeah, okay, great. Okay. So what I want to talk about today is how we approach the treatment of hallucinations in people with Parkinson's, and as we talked, a related condition, Lewy body dementia. And I suppose just to give you an overview, I'll touch very briefly on hallucinations and the distinction between Parkinson's and Lewy body dementia, because Angelica's covered that hallucinations in a lot of depth. I'll talk about how we approach treatment and all the things that we do before we even think about drug treatment. And then I'll cover the existing drug treatments and end with novel treatments that can be on the horizon. So, as Angelica's mentioned, there are different types of hallucinations. Now, minor hallucinations or illusions are common to all of us. I mean, I particularly have a sense of presence often, and I never know if it's my cat is there or not. But any of us who have pet always have a sense of presence around us. And And as Angelica said, it's our brains are wired to kind of seek for faces. And you can see here, my husband actually noticed a face in a fried egg when he was cooking breakfast some time ago. It's one of my favorite images because it really does appear to be a face. Now, when I get involved as a psychiatrist is when people are experiencing complex visual hallucinations, and I get involved really at a point when they're actually causing distress or impacting on life. But for many people who have hallucinations and see objects or people, they can be manageable if the person knows they're not real, and if the person's curious about them, and sometimes, you know, they can not impact very much. But I think if someone has hallucinations of a type that are distressing or threatening, or they have some kind of auditory narrative around it, which some people like to call an auditory soundtrack to the hallucination, then they can be distressing. And sometimes people can develop beliefs that are related to hallucinations, and that they develop a delusion. And again, that can cause distress. But also, I think if someone does develop a dementia and loses insight into the fact that they're not real, then again, that can be quite frightening. So Lewy body dementia and Parkinson's, we see them as part of the same spectrum. So there are similar core features. So the kind of what we call rapid eye movement sleep disorder, where people are acting out their dreams and moving when they're dreaming and shouting out, that's shared between the two conditions. They're also more likely to have falls and what we call autonomic disturbance. It's the nervous system that controls our gastrointestinal system, our blood pressure, our heart rate. So there are similar features. And when we look in the brain, when we image a chemical called dopamine, there's a reduction in dopamine production that's common to both conditions. When we look at the brain of people who have died, we see that there are similar deposits. And we also know that people with Parkinson's and Lewy body dementia are very sensitive to the medications that we use to treat psychosis, as we call it in young people. And I'll come on to that later. So the main difference, and the reason why we make this distinction, is that in people with Parkinson's, the hallucinations most often don't emerge for several years. And they can be associated with changes in memory and other aspects of cognition. In people with Lewy body dementia, what we tend to see is that memory and hallucinations are at the forefront, and they happen early. And some people with Lewy body dementia don't have any movement problems. And really part of that is because the Lewy bodies are in different regions in the two conditions. So the way they emerge, it differs. So that's why we have to make a distinction when we think about treatment. So we don't always need to treat hallucinations. Often, a lot of what we do is to help a person understand why they're happening and to help them manage their daily life within the context of these experiences. And it really is about what the experience means for the person and how it's impacting on their relationship. So when is the experience happening? What type of visions are people seeing? Are they happening several times a day? or just a couple of times a week? Are they severe? So there's something frightening. Do they cause distress? And I suppose the other thing that would make a difference is if they're potentially causing a risk to the person. So, for instance, one person I saw in a care home was actually, he was at risk of falling because people were coming into his room, he felt, and he began to think they were going to harm him and kept trying to escape his room, but he had a high falls risk. And so there are risks associated with him for trying to escape hallucinations. And again, you know, I'm talking about the most extreme end of the spectrum, where someone feels they might be harmed and is starting to sleep with a weapon. So those are the types of risk where we think, well, we really need to help this person and give them some additional treatment. So I thought the way Angelica talked about things like the bottom-up processes, so what's coming in through our senses, and then the top-down, which is our prior experiences and the way we assign importance to things that we're seeing. I think what we do in practice when we approach the treatment of hallucinations is that the way I put it is that we try and reduce any ambiguity in the environment. So we try and improve the way people we try and improve the bottom-up processing, so the way people are seeing things, but also try and improve the cognitive processes. So what you see here, this is, I suppose, I'm trying to depict the fact that if someone has a confusional state, or delirium we call it, that can happen if a person has a urine infection, a chest infection, a skin infection, or some other toxin that they've been exposed to, then that can distort all of our senses, and hallucinations can be increased, or new hallucinations can happen. I remember as a junior doctor, when I worked, when I was on call, having to give people intravenous antibiotics when they had infections. And I learned such a lot about the impact of infections on people's mental state, because I appeared behind the curtain, and this poor woman who was in bed saw me in a white coat, probably quite a pale face because I was sleep deprived, with a syringe. And she said, "Hail Mary, Mother of God." And she felt I was some demon coming to harm her. And I learned a lot about how we shouldn't manage delirium. Her senses were all distorted. So the first thing we do if someone's hallucinating is we make sure there's not something extra that's impacting. And I could see in the Q&A someone touched on this. What we would also do is make sure that we optimize vision. So if someone has a cataract, or if someone has reading glasses or other glasses that are out of date, then that will increase their tendency to misinterpret. So we optimize vision. The other thing that we do is, as we should have done with the lady who I went to see with my antibiotic injection, if anyone's hallucinating for any reason, you need to make sure that you're not creating shadows and increasing the misinterpretation. So you have a very direct light, and one that's ambient and allows people to see clearly. So the other thing that is really important is that we increase awareness. We call it psychoeducation. So it's education into psychology and mental states. And what we do is we normalize, we say just how common these symptoms are, because people often don't know just how common the symptoms are. And it's important that they understand it's part of their condition. We also help them to identify when things are more likely to happen, and think about triggers, how best to avoid it. So sometimes people will experience them more when they're alone and in the dark, so it's about thinking about how we manage that. And it's also about helping people to manage their anxiety, any anxiety that is associated with the hallucinations, or any tension it might cause between them and their family or their partner. So that's a lot of what we do. That in the community, we're working with families. In a care home setting, I would be meeting with the caregivers to help them understand what's happening, and working with them and the person to think about how we manage the routine. So before we even think about prescribing any treatment, we have to be aware that the treatment that we use to reduce the movement symptoms of Parkinson's can exacerbate hallucinations. And that's because the treatment that boosts dopamine can increase our propensity to misinterpret, and drugs that reduce a chemical called acetylcholine can impact on the way, very much on the way, on the precision of which we interpret things that are coming in through our senses, and can also affect memory. So the first thing that I would do is maybe speak to the neurologist who's prescribing medications and say, have you made any changes? Is there anything you might reduce? Perhaps the dose, perhaps the frequency, and let's reduce the number of medications. And so what you see here is published in JAMA, quite a highly impactful journal, and it was created. It's a mosaic created by a geriatrician from all of the tablets that she removed from people, which actually helped their condition. And it's always it's a deprescribing mosaic, and it's a very good lesson for all clinicians to deprescribe. So when we consider drug treatment options, one of the first things that we would think about, particularly if someone had any cognitive impairment, we would think about using a drug that is used to improve cognition in people with Alzheimer's, and they're called cholinesterase inhibitors. What these drugs do is they prevent the natural recycling and breakdown of a chemical in our brain that helps memory. So they allow this chemical in the brain to sit around for longer. And because we know that hallucinations can worsen if this chemical is reduced, by boosting it, then it could potentially help hallucinations. So rivastigmine is the most commonly used drug of this type in people with Parkinson's. And that's because clinical trials were carried out in which rivastigmine was used to try and boost the memory and the cognitive function of people who had dementia in the context of Parkinson's. And what these studies showed was that there seemed to be a reduction in hallucinations. We've never had a trial that focused primarily on hallucinations when we've used these drug treatments, but there's enough from those trials for people to say, well, let's use them as a first-line drug treatment because they're safe. They're the safest option that we have. But we do need more evidence about their effectiveness, and there are trials that are kind of ongoing in that. But So what we're doing with rivastigmine is we're trying to impact on the top-down processes, our memory and our insight and our ability to interpret. So the next set of drugs that we use are called antipsychotic medications. And we call they have their name because they were developed to treat schizophrenia. And they were developed to treat the delusions and hallucinations in people with schizophrenia. So what was originally done was that because these drugs are often used in young people, all that happened was the drugs were trialed at a slightly lower dose in people with Parkinson's. So we're extrapolating from one diagnosis to another and from a younger group to an older group, which is not very precise way of approaching things. And what we find is because most of these drugs act to block dopamine signaling. So because they do that, they can worsen the movement side effects, the movement in people with Parkinson's. And if people don't have any movement problems to begin with, they can cause Parkinsonism, so movement issues that look like Parkinson's. They also increase the risk of a stroke, and there's an increased risk of death. So some of that was about the fact that doses that were used were, I think, too high for people with Parkinson's, and we've learned over time that we need to use micro dosing because people with Parkinson's have more sensitive brains, as do people with other forms of dementia. But people with Parkinson's and Lewy body dementia are much more sensitive to these antipsychotics because of their dopamine function. So one drug you might have heard of is called quetiapine, and that's one of the newer drugs, and it acts at multiple sites in the brain, and it has a lesser action at dopamine. So it doesn't worsen movement, but it can cause sleepiness, and the evidence is quite weak. There's no evidence that it helps delusions, but one study showed that it did help hallucinations. In the UK, guidelines suggest that we should use this as a first-line antipsychotic because it's safer than the other drugs. So the most effective drug that we have to treat hallucinations in people of any age, of any diagnosis, is a drug called clozapine. And there have been clinical trials of this drug in people with Parkinson's. The first trial used too high a dose. The second trial lowered that dose, and it showed great effectiveness in reducing hallucinations. So in a young person, we might use somewhere between 300 to 800 milligrams daily. In people with Parkinson's, we have to break the lowest dose of tablet in half to actually start prescribing. And the drug is effective, but it does have some side effects, so you have to have very careful monitoring. And we also need to check the white cell count in the bloodstream every week for the first 18 weeks to make sure that someone hasn't got a reduction in those white cells and can't fight infection. It can cause constipation too. So neutropenia is that loss of white cells. So it's quite challenging to start clozapine. And even in a care home setting, I've often had to send people to an inpatient unit in hospital to start the drug because of all the checks, but it is effective. So in the UK, the guidance suggests rivastigmine or related drug, followed by quetiapine if that doesn't help, followed by clozapine. And that's all we have really. So,
Dr. Reeves, if you don't mind, I wanted to check in because that's really interesting about those three drugs, and it sounds like sort of the line of defense, the first line of defense, like you said, was the rivastigmine. I'm not sure I'm pronouncing them right, but the ones that you just listed. Now, is that similar in the US, do you know? Or is that just particular to the UK?
Well, from my understanding is, although we call them National Institute of Health Research of Clinical Excellence guidance, it's the guide, the body that creates the guidance in the US is different, but really those are the options that we have anywhere. There aren't really other options apart from a novel treatment that I'm going to mention, and the drug that I'm trialing. So yes, so that's really what we have.
Okay, so they're basically the same options in the US, maybe not in the same order, but they're all FDA approved as far as you know.
Yeah, okay. Yeah, definitely.
Okay, thank you.
I saw a question, and I'm curious if DBS like affects the treatment options, or is it similar with somebody who has had DBS surgery?
The treatment options are similar. So, so I think one thing that we would do is consider whether DBS has contributed to any changes in symptoms, but the options thereafter would be the same.
Great, thank you.
Yeah, so I suppose if we step back from everything we've talked about, I suppose what we're trying to do when we see someone who has hallucinations is we're trying to balance the expectations of everyone, and we're also trying to reduce the psychosis if they have delusions and hallucinations, or reduce hallucinations, but without impacting on the movement. And really, every drug that we give has a potential benefit, but a potential side effect. And so we keep things to a minimum amount of medications at the lowest possible dose. And one of the reasons that I moved from treatments to help people with Alzheimer's disease, one of the reasons I went down, I kind of moved sideways to look at treatments for people with Parkinson's and Lewy body dementia is that they have fewer treatment options than people with Alzheimer's. People with Alzheimer's can tolerate some of the antipsychotic drugs that block dopamine. So one of the treatments that has been since 2014, it's been very much on the horizon. It's been on the public agenda and also in the research agenda. It's a novel treatment called pimavanserin, and the reason it's of interest, if you look on the right, you can see something called 5-HT2A and 5-HT2C. Now, they are receptors in the brain. It's a different chemical than dopamine. It's a chemical called serotonin that affects mood and memory, but it's also very much involved with helping us process and interpret visual information. So, for instance, psychedelic drugs impact on serotonin and cause hallucinations. And some of the antipsychotics, there's my sense of presence. That's my cat that's come in to join me. So some of the antipsychotics, if we look at clozapine, it targets multiple receptors. If you look at the orange, it targets dopamine, but only to a small extent. And it has multiple chemicals and the proteins that control them. It targets all of them. Pimavanserin is really of interest because it solely focuses on the serotonin targets. And the reason it's of interest is that it has modest effects in people with Parkinson's who have hallucinations and delusions. And it doesn't worsen the movement. So we need more evidence about long-term safety. but it's approved in the US. It's not licensed in the UK, and because it's still under patent, so the pharmaceutical industry own it, then it's still of high cost. So it's not going to be feasible for use in the UK, but it is available in the US. And it's part of, it is part of the kind of guidance for clinicians. So in the US, clinicians have pimavanserin in their toolbox to try and help people. I suppose the other thing that pimavanserin has done is it's shifted the focus of research towards serotonin. And let me just remove my pen. So in 2018, I went on a search to see what novel treatments we might have. Not novel in that they've only just been developed, but treatments that could exist for one condition that we could repurpose to treat hallucinations. And out of all the drugs that I looked at, ondansetron, which is a drug that blocks a particular type of serotonin receptor, was the most promising. It's an anti-sickness medication. So if any of you have had a knee replacement or a hip replacement and were nauseous after surgery, you may have had ondansetron. So it was introduced in the late 1980s, and it revolutionized the treatment of nausea and vomiting. But during its development, when it was tested in animals, it was very much of interest as a potential treatment to boost memory, so pro-cognitive effects, and also because of its antipsychotic effects in mice. So if you look on the left, I always feel quite sad when I show this, but so they have particular mice that they give amphetamine to, and the amphetamine causes this massive release of dopamine. But also the mice have these little movements that resemble, which we presume a psychotic-like behavior. If you give something like clozapine, you reduce the amphetamine and you reduce those movements. If you give ondansetron, you have the same effect. If you give something that blocks dopamine, you reduce the amphetamine, but you cause the movement problems. So you can see similarities between drugs like clozapine and pimavanserin and ondansetron. And on the right, we have a different mouse. This is a mouse that lacks acetylcholine. It's a kind of model of dementia, really. And when you give clozapine, you increase acetylcholine and you improve the visual processing of the mouse. And the same happens when you give ondansetron. So the model on the right, for me, is very much very relevant for hallucinations. You're improving visual processing. It's also very relevant for the hallucinations that might arise as a result of dopamine treatment. So I was interested in the drug for both of those reasons. It was also interesting to see that I've never seen on the waterfront, but for me, ondansetron really is the Marlon Brando of the drug development world. It should have been a contender for clinical trials. In the early 90s, there were a couple of very small studies in which a series of people were given ondansetron. They had severe hallucinations, they all had Parkinson's, and 15 of 16 people responded. And in 14, they had a complete, resolution of symptoms. And they also had a reduction in delusions. It did cause some side effects of headache and constipation, but they were mild and everyone stayed on treatment. There was no worsening of movement, no worsening of memory. But unfortunately, it was very expensive. And it was only when Glaxo, who owned the drug, it came off patent, so they no longer had the rights to it in 2006. And since then, it's been trialed as an add-on treatment for schizophrenia. And Parkinson's UK decided that they would fund my application to run a multi-centre trial. So at the moment, I've recruited 115 people across 30 sites in the UK. Our top hat trial is a trial of ondansetron as a Parkinson's hallucinations treatment. And what we have is we're including anyone who's an adult who has either Parkinson's or Lewy body dementia. We're using a scale that we know is sensitive to change from the clozapine and pimavanserin studies. And we're looking at treatment over 12 weeks and comparing it to placebo. We use the first 6 weeks to gradually increase the dose so that people are on the right dose for them, because we know one size doesn't fit all. And we're looking to see if ondansetron will reduce delusions. We're looking at safety. We're looking at quality of life. And we'll look at the cost effectiveness as well. And we'll also take blood samples during treatment to see how the concentration of the drug in the bloodstream is linked with response and side effects, because that's one of my areas of interest. It's about precision prescribing. So we're looking to recruit 216 people with Parkinson's, because we're principally aiming the drug at people with Parkinson's. But we also want to understand more about how the drug acts in people with Lewy body dementia, because we can see that if ondansetron is better than placebo in treating hallucinations in Parkinson's, clinicians and people with Lewy body dementia will say, well, what about us? Can we have that treatment? So this trial will also give us information on Lewy body dementia. Yes, so we have people all over the UK, and we also have a site in Belfast that's just about to open. Unfortunately, we're not recruiting outside the UK. It was challenging enough to actually initiate a multi-centre trial. Just in one small island, particularly during COVID. But if it's successful, then ondansetron has been around for decades and could easily be prescribed anywhere in the world. So, yes, thank you for listening. And yeah, happy to take any questions.
Thank you so much. And it was great to have you end on a little bit about your top hat trial. It sounds great. Congratulations on meeting your almost getting halfway on your recruitment goals. I know that's probably was a big challenge, particularly during COVID. I thought it was interesting that you said that they had discovered some promising results back in the 1990s on this drug, and then things were sort of quiet, and you sort of resurrected the interest in this drug. Do you think it was primarily because it was on patent and it was too expensive? Or were there other reasons you think that it wasn't pursued prior to your grants?
Well, I think at the time, I've learned in the last 5 or 6 years a little bit more about the pharmaceutical industry, and it is an industry. They are trying to help, but it isn't industry. So people have to make decisions about the direction they're going to take their drug. And because it was such a revolutionary anti-sickness treatment, everything went down into that kind of pathway. Mm-hmm. So I was an oncologist in the mid-90s before I changed career and moved into psychiatry. And I remember that ondansetron was so expensive. We only gave it to people who were very severely unwell with their vomiting. But since the drug has come off patent in 2006, there have been several trials in schizophrenia where they've added ondansetron to existing medication. And those trials of people that haven't really had fluoride hallucinations or delusions because they're already on treatment, but some of their cognitive symptoms, particularly their visual processing, has improved. It improves visual attention. Mm-hmm. So that's really interesting, and I think very relevant.
Wow, so extremely promising.
Yeah.
It seems like there's some interest, there's some questions about the existing drugs in addition to the one that the trial is on. Pardon me, how do you say the word? The one with the Q?
Quetiapine.
Quetiapine. And it turns out that's also, we call it, I think the name for that here is also Seroquel.
Yes.
Okay, and we have one person that has chimed in to say that their husband has developed psychosis with Parkinson's, dementia, and the geriatric psychiatrist prescribed Seroquel, and he no longer has the paranoia and the hallucinations, and it's been about a month. He's on a very low dose, and it's going quite well.
Oh no, that's really good to hear, because I think it's very hard in clinical trials to see a difference between the drug and the placebo, and I think the trials of quetiapine didn't focus on hallucinations; they focused on a range of symptoms. So I think as a clinician, I know that some people will actually do quite well on quetiapine, but for those who don't, then clozapine is the next step. But yeah, it's really good to hear it's helping.
I mean, it does seem like, based on what you said and some personal experience that's coming through the chat, that there is a lot of heterogeneity in the responses that people have to the different drugs.
Yeah.
So what do you think is the best sort of strategy for sort of dealing with the different responses that people might have to the various drugs?
Well, I've talked to a lot of people, particularly in the last year, people who have Parkinson's, with part of focus groups. I've also spoken to my local Parkinson's UK branch in Barnet, and what really strikes me is just how sensitive people with Parkinson's are to anything that you do. If someone's sleep deprived, things get worse. If they're constipated, they don't absorb the medications in the same way, and it can worsen everything. And if there's an infection, it can make things worse. But I think even tiny tweaks in the medication that we use to treat Parkinson's can upset the balance. So I think it's all about tiny adjustments. So if someone has been sensitive to something, it's important to step back from it and think about the dose, think about anything else that could have been impacting, and to think carefully about if there's any medications that can be removed before you add anything.
Yeah, I think that's a common sort of question or concern that people have, sort of with the hallucinations and delusions, sort of how much of it is coming from the Parkinson's itself and how much of it is coming from the medication. And we did have one person ask a question about that. He says, my partner has had hallucinations for many years. He's aware that they weren't real, but now the delirium has become more intense and more of his reality, which have both fed into the paranoia. So they've trialed many drugs with only limited success. And I'm wondering how much of this is a consequence of the Parkinson's and what might be attributed to the side effects of the medications.
It's a question that's been debated for many years, and that we know that if people are on too high a dose of their dopamine medications, then that can precipitate hallucinations. In fact, in the last year, I was co-supervising a student who went back to original data from the Institute of Neurology at Queen Square in the days pre-levodopa. And what he found was that the incidence of hallucinations was tiny. So there was only one person out of 100 who was described when they were kind of seen by their doctor having hallucinations, and they were on a medication that reduces acetylcholine. So I think what we can say is that there is a greater propensity to have hallucinations if you have Parkinson's, and the drugs that we use to treat the movement aspects can contribute. It's one contributor. But as Angelica said, there are changes in the back of the retina. So we're, the acuity of vision is not as good. And the deposits in the brain are more likely to be in those pathways that connect the way we take in information with the way we perceive vision. So I think there are multiple factors. So yeah, it is very complex. And that's why we use these multiple approaches, in that we try and improve memory, we try and improve everything that we can to increase the precision of the way we are seeing things through our eyes. And we also try and help people gain insight so that whatever they're seeing, they can think, well, actually, this isn't real.
Right. I thought it was really helpful how you went through the sort of different steps, the sort of stepwise process that as a neurologist you would go through to help somebody. And I thought it was really interesting that you looked at infections first. And it just sort of goes to the question of there's so many other things that can cause hallucinations.
Yeah.
And then altering the physical environment and, making sure that you get an eye exam. And these are all things that I think it's really helpful for our members and our community to be aware of, because you don't often know the right questions to ask. And the neurologist and the movement disorder specialist, when you go in and they have, for 10 minutes for your visit, and they don't always know what the right things to ask are. I mean, we sometimes as patients and care partners have to really advocate for ourselves and ask the right questions and lead the conversation often. So I think that what you outlined was really, really helpful for the community. Thank you.
That's good. No, and I suppose what I would say is one of the things that we don't think about enough is, doesn't matter what age you are, analgesia can have a profound effect on our senses. I remember at the age of 17 having nerve root problems, and for the first time being given some, I don't even know what the analgesia was, but I have this distinct memory of hearing this and seeing this shape come up the bed. And it was my brother's, it was a Jack Russell that usually slept with my brother, but because he was away, was coming to see me. And it was his most frightening experience, but it was this distortion of the way my brain was taking in information. And so I think that there are some quite powerful analgesics around, codeine containing things, things like pregabalin for pain. So that lots of things can actually impact on the way the way we're processing our senses, because they dull pain, but they can also dull the way we take in other information. So
yeah, we did have a participant actually specifically say that taking hydrocodone has caused hallucinations for them, and was asking about why. I don't know if there's anything you can say more about why analgesics cause hallucinations.
So yeah, so it's quite interesting. So we know that drugs are developed because they act on a certain target in the brain or the body, but there's lots of overlap in between the brain and the body and the little proteins that we have. So let's take, for example, the drug that ondansetron targets. It acts in the brain and the vomiting centers, but also in the visual areas, but also in the gut, and that's why it causes constipation. So all the drugs that we use to treat hallucinations and delusions and schizophrenia also reduce sickness. So we know there's this big overlap between the chemicals in the brain and body, and analgesics, by reducing that sensation of pain, they do have an impact on our other senses. And if someone has Parkinson's and may already be struggling to process that information, then an analgesic on top of that can make a difference. But some people are more sensitive to codeine and related drugs. I know this because my family are, my mum, my brother, and I. So so I got strange kind of tinnitus when I had codeine, when I had my tonsils out and was lying on the floor with the world whirling, and had to survive with post tonsils on paracetamol and aspirin because I couldn't tolerate any other drugs. Similarly, my mum vomits when she has codeine and can't stand up, and my brother. So, and that's the way certain people, the way their liver metabolizes drugs. And you only realize these things. I only realize now when I'm looking at the way different drugs are processed. I look back and think, well, that's why we all have that reaction. So it may be that you are very sensitive to that class of drugs.
Interesting. Thank you. We have a couple hands up, so we'll go to a couple live questions. Richard, I just invited you to talk. If you would like to ask your question live, you can please feel free to do that.
You're muted.
Richard, if you're there and you still would like to ask your question, maybe we already answered it, but if you'd like to ask it, feel free.
Yes. Can you hear me now?
Yes.
Okay, I'm sorry, I was muted. So good morning to California and good afternoon to London. Nice to see you both. I spent many years in Bloomsbury, near to where you are, so very familiar with your institutional location. And my question is about this idea that you've, more than idea, this finding that you've commented on many times, that the drugs that we use to treat the motor symptoms of Parkinson's may be a significant cause of the dementia and psychosis symptoms of Parkinson's. Can you elaborate that a little bit? And let me put 2 or 3 specifics into that. Is this all about levodopa, or is it broader than levodopa? What is the culprit? What is the drug or drugs that we would like to reduce the 24-hour intake in order to have minimum impact on the development of hallucinations or dementia symptoms? That's one question. What about other Parkinson's drugs? Are they also implicated? On Gentis, for example. And my second question is, Madopar is quite commonly used in Europe instead of Sinemet, both with the levodopa, but then some differences. What do we know about Sinemet versus Madopar as a partial cause of hallucinations and dementia in Parkinson's patients? Thank you.
Mm-hmm.
Before you answer that, could you clarify what the other drug is for people who might not be familiar with it?
Yes, Madopar is, I don't know whether it's widely used in the UK. It's widely used in Europe, in Switzerland, for example. It is levodopa plus an alternative companion drug. So it's that second drug that is different. And I don't know the name for that. I would have to look that up.
Yeah, so really interesting questions. Thank you. So what, I suppose, before we talk about hallucinations, I don't necessarily think that the Parkinson's drugs cause dementia, but they can contribute to hallucinations. Yeah, so but the drugs we use to treat delusions and hallucinations can impair memory, depending on the drugs that we use, but these things are quite difficult to disentangle. So hallucinations are more likely to happen if there are already some cognitive changes. Doesn't necessarily mean that the person has a dementia, but sometimes hallucinations, can precede the onset of some memory problems. So so that's because similar areas, so the parts of the brain that help us to recognize objects are also involved in memory. So there is some overlap with the memory of objects as well as memory for other things. So there are some existing or emerging memory issues happening in some people that have hallucinations, but that's not about the Parkinson's treatment. That's part of the condition. So there have been quite a few reviews written about the fact that there's a contribution of Parkinson's medication to hallucinations, but they're not the whole cause. But because we know that they might be contributing, there's guidance for neurologists about the order in which people should try and reduce medications in terms of the type of medication and the frequency. So as a psychiatrist, that's not something that I get involved with, because it's, that's, I don't prescribe those medications, and it's very much the neurologist who will make any changes. But one of the issues is that hallucinations are more common the longer someone has Parkinson's, and so what you find is that if you reduce the Parkinson's treatment, then you're going to worsen motor symptoms in many cases. So it's a very, this is why I say it's walking a tightrope, really. We're trying to balance the hallucinations and the movement.
Yes. And is levodopa the prime culprit, if that's the right word, is the prime focus of this effort not to, sorry.
No, it's not the only. So some of the Parkinson's medication will boost dopamine, but others will actually reduce acetylcholine. So both can contribute, because acetylcholine is involved in it's also part of those pathways where that helps us to understand incoming information about vision and other senses, and also helps us to recognize what we're seeing. So they're both, a dopamine helps us assign importance or salience to things, and it's very important in interpretation. So they're both important, but in different ways. So that's why the neurologist might suggest tweaking any of the medications, really.
Just if I may kind of jump in regarding the specific questions. So we tend to, I think what you're leading to, Richard, is that actually the dopamine agonists are one of the main things that we would try to minimize. Things like a rotigotine patch or things like that are actually much more common contributors to hallucinations. So from a movement perspective, levodopa is actually the one that we tend to keep, just because it's easier to then balance and maintain a quick, like a good enough dose during the day from a movement perspective. So we tend to kind of move towards more levodopa. In terms of your Madopa versus Cinemas, that's a big debate. I don't think there's any, there's actually a lot of equivalent studies. So the only thing that they differ with is the agent that stabilizes the levodopa in the stomach to make it essentially last longer and not to produce systemic symptoms. So it only acts in the brain. They don't, the levodopa element is the one that actually is the main ingredient, and we wouldn't expect to see any difference between the way that Cimet versus Madopa acts. We kind of use them quite interchangeably, actually, when people come into hospital. And I don't think there is any evidence that one is better than the other, even in terms of movement symptoms or anything else. So I think it's just the way people are familiar with one other, and different pharmacists in different hospitals I work with have a preference of one versus the other in terms of which contract they have signed. So I don't think there's any particular difference between them.
See, this is why we work together.
Yes.
I always say, neurologist, how are you going to manage this? And then I come in with what happens next.
Yes, for sure.
And thankfully, we have very joined up working between my trust and the trust that Angelica works with. So yeah, so that's why it's really important to have people from multiple disciplines and backgrounds involved. And actually, the Top Hat trial has really shown me just how important it is to involve geriatricians, neurologists, neuropsychiatrists, old age psychiatrists, psychologists, and Parkinson's nurses. And it's very much a community, and we all bring slightly different things.
It's a complex disease, isn't it?
There's a it is really interesting. There's a member who asked about when you said that you usually don't treat hallucinations unless they're causing distress, but the previous presentation earlier said that it actually can reduce the chance of developing Lewy body dementia. So why wouldn't, if hypothetically, if somebody was starting to have hallucinations, could they then say, you know, please treat me for my Lewy body dementia that's going to start developing? I don't know. I'm just kind of throwing it out there, kind of combining the two. And it was a member who asked, and I was thinking the same thing.
Fault.
Well,
no, it's at the moment we don't have, just to make to be kind of a bit clear, I think we don't really have any disease modifying treatments for Parkinson's dementia at the moment. We have symptomatic treatments that boost acetylcholine, as Suzanne said, to make people's thinking and memory better. I think it would be useful now for we start having, you know, disease modifying treatments targeting amyloids, for example. You've seen, I'm sure, for Alzheimer's disease recently in the news, but also amyloid plays a role in Parkinson's disease dementia as well, and there's starting to be disease modifying treatments and trials targeting alpha-synuclein and Lewy bodies as well. And I think those are now it's a research basis of trying to capture those people who are early at the exhibiting the very first signs of thinking and memory problems, and part of that is hallucinations sometimes, and trying to use these disease modifying trials for research and see whether they make a difference. At the moment, I don't think the drugs that we have available for clinical use, not as part of research, actually wouldn't make any mechanistic difference unless people they are symptomatic. So as Suzanne said, they will just manage the thinking and memory. They will improve it a little bit, but only they will not affect how the disease progresses, essentially. So that's why we don't really recommend currently, with the treatments that we have, to treat hallucinations unless they are problematic. I think that might change whilst new treatments develop. I hope, anyway.
Yeah, and I suppose just to also say, when we say do we need to treat, so the other reason why we only step in with treatment if the experience is distressing is that there are risks associated with every drug that we give, and the drugs like rivastigmine are the first line treatment because they can help the top down processing, they help the memory, but everything else is a potential risk, and that's why we hold back and try and do everything else, help to optimize the environment and the person's vision. If we have safer treatments, then we could step in earlier.
Someone actually did ask about cognitive behavior therapy. We've talked a lot about treatment and medications and that kind of approach to hallucinations and delusions, but do you do some kind of cognitive behavior therapy type approach or something non-medication?
See, that's very interesting, and I think the psychological therapies have been under-researched, but there is there is a move towards psychological intervention. So identifying triggers, kind of the cognitive behavioral therapies, I suppose. It's so So sometimes it's as simple as identifying when it happens and distracting. Some of it could be around anxiety reduction techniques, stress reduction. Some of it could be around sleep hygiene, making sure you optimize sleep, and if that's when things are happening. But there are also therapies that we call third wave therapies. So they're like cognitive behavior therapy, but we move a step on in that we're mindfulness, for instance, is where we're kind of it's about understanding our feelings and managing them rather than trying to change our thoughts and behavior. It's understanding them. And there are other ones called acceptance and commitment therapy, which is about, I think, understanding our emotions and thoughts and thinking how to optimize our quality of life and how we can still be the person that do the things that are really important to us despite having these thoughts and feelings and experiences. So there's a lot of work that's going into trying to do research into how well these therapies work. I didn't get a trial funded. We were trying to get funding for virtual mindfulness sessions with a psychologist to look at the feasibility, but we didn't get that funded. But it takes time. It takes time. And I'm also looking at acceptance and commitment therapy and working with a psychologist who is a trialist in this area, and we're doing interviews with people with Parkinson's to think about how we might adapt acceptance and commitment therapy specifically for people with Parkinson's. So there's a lot of research happening in this area, but we don't. I think the way services work, not every service would have access to a psychologist unless they're within a mental health trust or a specialist centre like where Angelica and people she works with.
Yes, and it just speaks to the issue of the multidisciplinary approach and how important it is to have a psychiatrist also involved in doing this research in addition to the neurologist, and also speaks to just how important it is for patients and caregivers to advocate for themselves for psychoeducational services.
Yeah,
so that's wonderful. Thank you for that question. We have a few questions that I think people might be interested in asking live. A couple people put their hands down. I was about to call on them. And they put their hands down. Okay, well, I think Ben Rivers, let's see if you are there and you would like to ask your question. You could go ahead and unmute yourself. Ben, if you're there and you'd like to ask your question, we're ready for you.
So if you check at the bottom left, I think you're still muted.
He may have stepped away for a minute. Yeah. I think Herb is also asked another question, so I'll go ahead and let him go if you're ready, Herb.
Yes, hi again, or hi to you. So I just about 3 months ago started taking Duopa, which is called Duodopa, I think in England. And I'm curious if you've looked into how that affects the possibilities of hallucination. And because I guess I'm on a bit of a mission because I think that it matters that it be continuously delivered. I think our we do much better with the continuous delivery of medicine. I think dopamine is different. I think it was much more like diabetes as a disease than anything else. I think it's not the same. And by the way, when I love your approach, and it's very reasonable to say minimize medicines, but when it comes to L-Dopa, dopamine, I question that. I think we have to optimize it. It's not, you can't, it's very important, as you say, that we be sensitive. And I guess that's essentially my question. I want to stop there. Have you done anything with Duopa?
Now, just for the audience, I think that the Duopa is the one that you goes through the intestine and is sort of a constant delivery of levodopa.
Yeah, it's infusing dopamine constantly. Correct.
Okay.
So I can say a little bit, unless you want, Suzanne. So essentially,
Yeah,
for
use it.
us, Herb, in the UK, I don't know if it's different in this States. Apologies, but for us, Duodopa is only part of the advanced therapy. So by definition, we only use it the same as apomorphine, which is another continuous infusion of a different type of medication. So we can only use it at the same at advanced stages of Parkinson's disease. We cannot use it early on. The same with DBS. So it's only part of the very strict cutoffs, and we're only very limited by those essentially. So to my knowledge, there's only been one real study looking at people who have had Duodopa and the prevalence and the effect of that in non-motor symptoms like hallucinations. And quite a lot of people did experience hallucinations. So like 65, or I think about 65% had hallucinations that were receiving Duodopa, and that's a little bit higher than what we would expect in otherwise in Parkinson's. But again, they had, because it was a UK study and it was quite significantly more advanced, so they had Parkinson's for quite a long time longer. So it's difficult to say whether the continuous delivery method actually by itself plays a role in the development of hallucinations. I get your point about the continuous delivery, and I think it's something that we in a sense try to do with the normal levodopa preparations as well. So we try to time them right during the day, so you always have a certain level of levodopa in your system. But it's interesting that that for us, these sort of medications that offer continuous delivery, we haven't really assessed them in early disease, and we don't really know whether they have a benefit or not. It's something that has changed as well in the mentality amongst neurologists as well. So in general, so before 10 years ago when I was 15 years ago when I was in medical school, it was all about first line was only dopamine agonists, and you were trying to reserve levodopa for later on to avoid having fluctuations. And now things have changed, and actually we know that you might be better off starting levodopa in some cases early, and it's all about a discussion with the person who has Parkinson's disease about, these are the risks and the benefits. This is your risk with levodopa. You may have a little bit more chance of having fluctuations later on, but you have better benefit in the beginning versus if you have an agonist. And I think there is a change in the mentality of the profession to trying different therapies at different stages of the disease, and actually relying on the data and trialing these things rather than just conceptualizing them and think, oh, this must be better, X must be better. I think we are trying to figure out the answers to all these questions. It does take a little bit of time.
Great.
There's absolutely been a change, and I'm very grateful.
Fair enough.
But 23 years I've been at it and trying to do it that way. So people who are newly diagnosed, I hope they don't lose sight of the ball, which is be as well as you can be, get the right amount of dopamine to live your life, and then I think that's the long-term strategy.
Yeah, I think that's fair enough, but I think it does differ. Like different people have different needs, so it's all about having that discussion. I think overall in neurological diseases, I think even like if you think about multiple sclerosis, the way that we thought about treatment and initiating treatment has changed so much, and the profession used to be very like authoritative in a way and kind of mandating treatment. I think that is changing quite a lot, and you have to acknowledge that you're just there to help the person who's living with the condition, and you have to take it from them to tell you what their priorities are and what they need. And some people want to be as good as you say, want to be as good as they can in the beginning and then deal with problems as they emerge. For others, they are quite happy to tolerate different degrees of off periods or on periods, and they don't want to take medications until later. And both are fine because they are what the person needs, I think. So it's just we have to offer both and see what's best for everyone.
Thank you for the question. It looks like Ben is back on with us and was unmuted for a minute. Ben, are you there? There you go. Can you you want to ask your question, Ben?
Yes, can you hear me?
Yeah.
Yes, I've had experience with dopamine agonist called Neuropex. You
Neuropex.
Yeah, it's a dopamine agonist. It's pramipexole hydrochloride. And my experience with it is it greatly in a speech better, but it caused severe memory problems. I was in a master's program. It took me 8 years to do it, so I'm only doing 2. So I wanted to ask you for your experience with pramipexole, and also I had a question. Oh yeah, short-term memory and executive function. I looked in. It took me a year to come off the pramipexole, and when I did, my function greatly increased, but I'm still having severe cognitive problems. Studying a few pages is taking me a week. So, any thoughts on these? Thank you.
Thank you, Ben. I'm not sure if there was a specific question you had.
Have the speakers had any experience or heard about pramipexole influencing the ability to speak, but more than anything else? And why would the removal of why would the removal of pramipexole make my speech that much harder? And the other question was about Parkinson's and cognitive function, and especially executive function, short-term memory, working memory, and whether since the pramipexole is gone now, the other culprit could be time-release amantadine. It's called recovery in this country. That there seems to be a complex networking between that and the levodopa, because when I switched to Angentis, which is a time-released newer version of the yeah, I have a lot of questions.
Okay, thank you.
Yeah, thanks, sure.
Angelica, did you want to try to address some of these questions? And we're going over a little bit. Is that okay? It's 11:02 here.
Okay.
So we'll try to wrap up in the next few minutes.
So regarding pramipexole, we do use it in the UK. I'm not aware of it specifically. I don't know why it would specifically have an effect on speech by reducing it. So probably, well, I'm not sure is the answer. I would suspect this because it's kind of long acting. You probably, obviously with like minimum time to actually have a proper opinion. My one guess that comes to my mind is that because it is quite long acting, maybe you just had kind of this not levodopa, but dopamine agonism effect that kind of has worn off, and then just kind of affecting the speech. We tend to use quite a lot of specific speech language therapy technique called the Lissivamod technique in the UK, which tends to help quite. It's a technique actually that it was developed by actors, I think. It was about pronunciation and kind of projecting voice, and do these exercises with speech and language therapies that tend to have a very good effect. So I would definitely, anyone who has a problem with speech, I would definitely suggest that. It's worth a try with speech and language therapy. So for the executive function and the thinking memory, this is something that we see quite a lot. So obviously, you know, as Suzanne says, so you have to like look at the same thing. So if I could see if there's any underlying other problem that contributes, such as infections or anything else, look at the medication, try to optimize reduce things that may affect thinking and memory, increase things that can help thinking and memory, and thinking about, you know, things like boosting acetylcholine, like rivastigmine and things like that. Also things that anyone can do to help thinking and memory is kind of improving hearing, improving seeing, so being social, exercise, all of those things are good for the brain in general, and they're definitely good for the brain in Parkinson's. So I would definitely recommend everyone to do those things. I don't know if that answers your question. Probably not. But...
Do you know anything about time-release amantadine and its effect on cognition? Confusion is one of the side effects. I've noticed.
One of the side effects of
two drugs besides the Brown-Paxil that it seems to have an effect. One is the time-release amantadine, and the other is the called and cacapone. You know anything about those two? How they affect working memory?
So entacapone essentially just prolongs the amount of time that the levodopa tries to stay in your system, really. So with all of these medications, thinking and memory is part of these. So problems with thinking and memory and increased confusion is part of the side effect profile, for what it's worth. It's very difficult to think to be, so all of these things, is it the drug causing it? Is it the underlying disease? It's difficult to say. If there's a very clear time correlation that you started entacapone and then your thinking memory got worse, then yes, it might be worth trying something else, for instance. But they're not ones that typically make thinking and memory much worse, essentially. So they're not ones that are red herrings for us when we see people, like things that are used for pain, so like amitriptyline and things like that, or pregabalin or gabapentin, the things that are usually analgesics for nerve pain or for somatic pain, like codeine or things that have opioids in them. They are the ones that are like red flags. These are the things that definitely do make people more confused, and these were the things that we would try to reduce. Entacapone is not one of those, but theoretically it can affect thinking and memory.
Thank you very much.
Wow, this was amazing. Thank you both so much. I'm sure Monique has some things to say, but I just wanted to say thank you very much. It was awesome.
Oh yeah, I was just going to say the same thing. This has been really fantastic. We've had a lot of chats, a lot of comments coming in the chats, thanking you both for all the interesting information that you shared with us. And just to the audience, thank you for joining us. We will be sending out a recording of this talk along with the copies of the presentations. And I can share the email addresses, I think, of both Dr. Reeves and Dr. Zarkali if they have any questions. I think you're probably welcome to email them. Is that right? Did you guys have any parting comments or anything that you wanted to share before we sign off?
No, it's no, thanks so much everyone for all of your thoughtful questions, and yes, I've really enjoyed meeting you all virtually. So and thank you for inviting me.
Yeah, thank you for sharing. Thank you for sharing your Saturday evening with us.
Thank you so much.
Okay, we'll go ahead and sign off then. We're already eight minutes over the hour. So. Okay.
Thank you.
Have a great weekend, everybody.
Thanks, everyone.
Bye-bye.
Bye.
Bye.